Dr. Aditya Kelkar. He is the director NIO Pune. No need to give any extra introduction. He is just an international figure. He is getting the International Hero Award for successive 4 years from ASRS, Reed Buckland Award.
I must thank Dr. Maiti and Dr. Boral for this award, actually speaking, because it's because of them and of course Dr. Chirag that I started going to ASRS. Otherwise I was completely out of this ASRS gang. So when Dr. Boral gave me this responsibility of presenting my longest retina day, I realized I don't have a longest retina day, but I have many days which are very long. So I tried to select a couple of them. This is one lady, pseudophakic patient, underwent vitrectomy, silicone oil, tamponade, retinal detachment with multiple breaks. In post-operative follow-up, cystic subretinal fluid space filled was noted, retinal detachment PVR was noted, and so we decided to go back in and drain the silicone oil, encirclage, buccal for managing the anterior PVR. So first of all, because of the extensive anterior proliferations, we decided to place a 240 band. So the muscles are isolated. It's a standard way of dealing with a anterior PVR case. A scleral implant has been planned, so the scleral pockets are made, and then 240 band is used for the encirclage element. After that, we started removing the silicone oil, and then fluid exchange was done. We stained these membranes and extensive proliferation was noted, and this was carefully removed. So here we are taking care of the anterior proliferations, and extensive retinectomy was also required. So diathermy followed by retinectomy has been done. And as you can see, silicone oil globule starts to pop out of that area. Now my silicone oil cannula cannot reach there. So obviously the cutter was taking too long to remove it. So ultimately that area was drained. Then I put back PFCL so that to allow more silicone oil to come up anteriorly. You can see there are extensive proliferation subretinal bands too. So as I put in PFCL, some more silicone oil escapes out from the retinectomy site, which was then removed. And then I reduced the height of the PFCL bubble because now there is a subretinal band which I want to remove. So I did a small drainage retinotomy, and silicone oil and a subretinal band was removed from the subretinal space. You can see another bubble of silicone oil now just under the retina. So once this subretinal band was taken care of, the silicone oil globule was again removed from the same area. It gets really difficult because the silicone oil removal cannula doesn't reach that far, and our 25 gauge vitrectomy cutter is too small to aspirate the silicone oil from subretinal space. But that was the only option, but at least it can create a kind of drag to pull this silicone oil out. So it's like a cyst. Maybe sometimes you can correlate it with a cystosarcosis cyst, the way it comes out. So I initiate the vacuum and at least bring the silicone oil out of that retinectomy area first. And it actually makes your day extremely long because, as you know, this silicone oil is so stubborn, it doesn't come out so easily from that space. So after that, endo laser has been done, and then we reintroduce the silicone oil after all the silicone oil under the retina has been aspirated. So PFCL is removed, the fluid exchange done, and then the silicone oil was injected. This is the post-op picture, at least the central area still looks attached. Now this is another interesting story where we have a dislocated capsular bag complex along with the intraocular lens, and we decide to bring it out, and we believed that it will be a routine straightforward situation. So PFCL is put behind the lens, and then this bag complex is held with the help of forceps. I've already made a scleral tunnel, so I thought it's going to be straightforward. But here my forceps get entangled with something, and now I cannot even leave the lens out. So I unintentionally drag the capsular tension ring from the side port, and the intraocular lens is now in the middle. So I leave that alone and bring the IOL bag complex out. But as I realized that it's not a complete ring, on the lower side it appears to be complete, and thankfully I had the PFCL behind, so I could go back and check, remove the PFCL, and also removed this segment of capsular tension ring which was left behind. So when you remove the capsular bag complex, be careful to make sure that all pieces are out and some inadvertent rupture hasn't happened. And this was then followed by secondary implant of my choice is the iris claw IOL. So the complications are unintentional obviously and inevitable, but at the same time because of the nature of the surgery. However, a prompt recognition and management can significantly impact the post-operative prognosis. Thank you again. Thank you.
Thank you, Aditya. Nice talks. But my question was on first case, like in your subretinal silicone oil. What was the there was the rationality of silicone oil migration of silicone oil into the subretinal space. It was the new traction. So whether the traction was present before and it was a new traction.
Yeah. So this
because you have already settled the retina during the surgery.
Correct.
So that means the traction was not there.
That's
maybe
correct.
you have done the all kind of good vitreous base excision, all kind of ear removal meaning. But again, when you saw the patient post-operative period gradually.
So the patient had come back with a PVR.
PVR.
And
okay.
with that, maybe multiple breaks, and silicone oil probably was already emulsifying.
The new traction. Yes.
One short, wonderful videos as usual. I think pictures. Did the silicone same because we are in the topic of the second ठीक था. Did he have a pre-existing nasal break through which you enter, or you made a retinotomy?
No, I first made a retinectomy nasally to remove the silicone oil from that area.
Peripheral?
Peripheral. And then there was a subretinal band on the temporal side, which I was anyway going to pull it out. And through the same opening, I removed the silicone oil.
And most important thing, you have to remove the subretinal silicone oil not under air, always in the fluid
That's
condition. Right. And also better to inject PFCL what you have given.
Yes.
Just for the complete removal of the subretinal silicone to migrate into
in his
cavity.
case, Aditya could not avoid the posterior, but Professor Klaus Eckert says the retinotomies have to be as peripheral as possible, always.